Alrighty, good morning. Once again, I am Dr. Russell Brown. I'm going to admit someone else. Alrighty. Yeah, I'm Dr. Russell Brown. I'm the medical director here at Avinia Behavioral Management. We are a mental health staffing agency. We source out psychiatrists, nurse practitioners, and physician assistants. Um, we provide collaboration services. And as part of that, we have to provide a medical education program um, via the state of Georgia requirements. So this is the my case study presentation program, and the resources. I just need to mention them. The main resources: psychiatric case studies for advanced practice, first edition by Prendergast, Prendergast, and Jackman, Jackman. We also use Case File Psychiatry, sixth edition by Toy and Clayman. Clayman is Klamen. We also use Adult Psychiatry Case Vignettes, second edition by Tavakoli, Tavakoli, as well as Child and Adolescent Psychiatry Clinical Cases, first edition by Amador. I'm going to admit a few more people into the meeting. Alrighty, so we can go ahead and get started. Today we're going to be discussing Mania with Psychotic Features. That's the name of the case study. This is case study number 32 in the psychiatric case studies for advanced practice. Let me admit a few more people. All right, great. I'll go ahead and get started. And once again, I don't have anyone on mute, so if you do have a question, um, you can just ask, but I'll go section by section and then I'll stop and ask if anybody has any concerns or issues. So let's go ahead and get started. Hopefully, everybody can hear me, and I'll put my volume up as loud as I can so I can hear you guys if you have a question. All right. Case number 32, Manic with Psychotic Features. Identification. The patient is a 29-year-old single, unemployed Hispanic male who's admitted to a voluntary inpatient psych unit. Chief complaint: I was just trying to find the truth so I can save the world, quote unquote, from the patient. History of the chief complaint: history of present illness. Prior to being admitted to the inpatient psych unit, the patient was taken to the ER by police. The police were called when he was observed wandering for hours in a parking lot. Approximately 1 month prior to his admission, the patient had been fired from a job he only had worked for about 3 weeks, and he was fired for inappropriate behavior. According to his mom, the police had to be called to escort him from the premises because he refused to leave. Since that time, the patient has barely been sleeping, and his family heard him laughing and talking to himself during the night. The patient said his appetite has been non-existent for the past 2 to 3 weeks. The mother said that although the patient is usually frugal, he has recently been spending excessive amounts of money buying expensive business suits, which he has been charging to a credit card because he has no source of income. The patient said he was working on creative projects that will save the world, but is not at any liberty to talk about. He is religiously preoccupied and speaks of his special relationship with God. He is sexually preoccupied and has been making sexually inappropriate comments to the female nurses in the emergency department. All right, we'll move on to the past psychiatric history. The patient has no previous hospitalizations. He had never been prescribed psychiatric medications. The only outpatient treatment he had was some counseling The previous spring at the university where he had been attending school, he said he did not find the counseling helpful. Even in his current mental state, the patient does have some insight into what is occurring with him and said he thought he might have bipolar disorder. He reports that for the past 4 years, he's been having episodes which could be described as hypomanic a couple of times a year in the spring and in the fall, increasing in intensity to the point that he failed his graduate program last spring. He said he also had periods of extreme depression where when he would not even be able to get out of his bed. The family said that because the patient had been living away from home, they had not been aware of any of his problems until this current episode, during which they had been trying to get him to seek some help. So, anybody have any questions thus far? Identification, chief complaint, history, present illness, past psych history. Any questions, concerns, need for additional information?
No.
All righty, good. We'll keep going. Medical history, the patient has no known drug allergies. He does not have any current medical issues. But in 2008, he did have a bleeding stomach ulcer that required 3 or 4 days in the hospital, and he had to have 3 blood transfusions. He's currently in good physical health, of normal height and weight, and stable vital signs. Um, Labs on admission that included the CBC, Comprehensive Metabolic Panel, um, Comprehensive Metabolic Panel. Trying to let somebody else in here. Uh, uh, but anyway, comprehensive metabolic panel, TSH and thyroxine were all in normal limits. History of drug or alcohol abuse. The patient says he began drinking alcohol and smoking marijuana at the age of 17. He considers himself a binge user of both substances, the alcohol and the marijuana. He says months will go by without him smoking marijuana, and then he will have a period of incessant cannabis use. He said the same is true of his drinking, and he has experienced blackouts during his alcohol use. The most recent episode of binge drinking was about a month prior to this hospitalization. His blood alcohol level and urine drug screen are both negative at this admission. So it looks like he's been binge using, but he doesn't have anything on board at this time, nor anything in the last 30 days per self report. Family history, the patient's older brother and paternal aunt have bipolar disorder. Um, the brother's illness is well managed. His brother lives independently and has completed his education and is a gainfully employed professional. A maternal cousin has schizophrenia. The patient was raised in a family where the parents have an intact marriage and are both employed and are financially secure. The patient is the second oldest of 4 children, having an older brother, a younger sister, and a younger brother. He is currently living with his parents and his younger siblings. He describes himself as being close to his mom, but having a more contentious relationship with his dad. He says that he gets along well with his siblings. All righty. Any questions about medical history, history of drug or alcohol abuse, or family history?
Mm,
All
no.
righty. All righty. Let's move on to personal history. Um, I think there's somebody in the background too that's doing a little bit of moving. So if you want to mute yourselves, you can. Um, or cut your mic down. Um, anyway, personal history, perinatal There's no information known. Childhood, he had no identified problems during childhood. He did do well in school. Adolescence, he did well academically in high school. Adulthood, after college, he was accepted into a master's program in which he struggled until dropping out this past spring, at which time he returned home to live with his mom and dad and his siblings. During the first year of his master's program, the patient was arrested for trespassing and resisting arrest. He said he was intoxicated with alcohol at that time and that the charges were dropped. Initially, after returning home, the patient was able to function in a job as a sports coach to adolescents. However, he left that job to take the one from which he was recently fired. Trauma abuse history. The patient denies any history of trauma or abuse, saying that he had a wonderful childhood. All right. Before I go on to mental status examination, does anybody have any questions about the historical data? Everything
No.
should be pretty clear about his history. All right. We will move on to mental status examination. Appearance. The patient appears his stated age. He is impeccably groomed and wearing a business suit. He is cooperative with the interviewer and makes appropriate eye contact. Behavior and psychomotor activity. The patient is very energetic and animated. Consciousness. He is alert. Orientation. The patient is oriented to time, place, and person. Memory. Uh, the patient is not formally tested for memory. He was able to recall events in his life, giving the exact dates. Concentration and attention. The patient was easily distracted by things in the environment. For example, in the middle of a sentence, he was distracted by a small detail in a painting in the room, and he spoke about it at great length. He needed frequent redirection to get back on topic. So he sort of goes off the rail a little bit with extraneous stimuli. Abstract thought. The patient's responses indicate that he is able to understand concepts and generalizations. Intellectual functioning. The patient is above average in intelligence, as evidenced by his vocabulary and his general fund of knowledge. Speech and language. His speech is spontaneous, overproductive, and somewhat pressured. Perceptions. The patient denied any hallucinations and did not appear to experience any perceptual distortions. Um, 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 Thought processes, these were tangential with some flight of ideas. Thought content, the patient displayed grandiosity, religious and sexual preoccupation, and some mild paranoia. The patient complained of having intrusive thoughts about other people and fearing that they could read his mind and knew what he was thinking. So there's a little bit of some psychotic processes or features going on with him. Suicidality or homicidality, the patient denies any suicide plan or intent, but says he sometimes wants to end it all. His family says that he has threatened suicide when intoxicated. He has never attempted suicide. He denies homicidal ideation, but says he often gets very angry with people. Family says he becomes quite angry when intoxicated, but denies he has ever become physically aggressive. Mood. His mood is elevated and expansive. Affect. His affect is over animated and congruent with his elevated mood. Impulse control. This is impaired as evidenced by his excessive spending and inappropriate sexual comments. Judgment and insight. Um, Although the patient has impaired judgment, he has considerable insight into the fact that he has an illness and needs medication and treatment to manage it. All right. Any questions about the mental status examination? about the data
No.
that was gathered? All right, it's pretty clear. All right, so now we're at the formulating the diagnosis. Question is now, what diagnosis should be considered? And the author here has two diagnoses. One is bipolar 1 disorder with mood congruent psychotic features, and the current episode is manic. And the second diagnosis is um, alcohol use disorder, moderate. And then we have a differential diagnosis, which should be considered, and that is cannabis use disorder. All right. So we'll go ahead and talk about these three disorders. Does anybody think that there's any additional psychiatric diagnosis that could be made other than bipolar 1 or alcohol use disorder and a consideration of cannabis use disorder? Did anyone have any other ideas or thoughts?
What about the intermittent explosive disorder?
Intermittent what now? I didn't hear you. You broke up.
And I'm sorry. Can you hear me now?
I can hear you now. Yes.
The
You said
intermittent explosive
disorder.
disorder.
Yeah. I mean, why would you think he had intermittent explosive disorder?
I
What
mean,
are
I
some
guess
of?
it's alcohol induced. I think because the anger episodes.
Yeah. I mean that is a consideration. Um, but with his history of the moodiness and everything
Okay.
with the intermittent explosive disorder, there's not a background of depression or real mania that goes on.
Okay.
You know, yeah, intermittent explosive disorder, people are pretty okay, and then it's almost like they have a seizure, and they just get angry, physically aggressive, and then they kind of come back down after those episodes. So those episodes are a little more discreet,
Okay.
and there's
Got
not
it.
really a backdrop of anything effective going on. Okay. Anybody have any other diagnostic considerations before we dive into these three? But well,
No.
if you do, I'll ask you about some other. I'll ask you about that later. But anyway, so let's talk about bipolar 1 disorder. All right, diagnostic criteria. For a diagnosis of bipolar 1 disorder, it is necessary to meet the following criteria for a manic episode. And the manic episode may have been preceded by or may be followed by hypomanic or major depressive episode. So that's a key point right here. In order to have a bipolar 1, you got to have a manic episode. But you can also have hypomanic episodes, which actually describe bipolar 2. So, the real difference between bipolar 1 and bipolar 2 is full manic versus hypomanic. Hypomanic, bipolar 2, full manic, bipolar 1. Um, and we'll talk more about hypomania after we describe full mania. But anyway, manic episode. A, you have a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally or persistently increased activity or energy lasting at least 1 week and present for most of the day, nearly every day, or the duration of the hospitalization, and or ill, or any duration if hospitalization is necessary. And that's a key point. A manic episode is one that causes a lot of pathology or a lot of disability or impairment to the point that a person probably has to be hospitalized. Whereas hypomania, uh, it doesn't cause that much impairment, and we'll hammer that down a little more as we talk. B, during the period of mood disturbance and increased energy or activity, three or more of the following symptoms um, or four if the mood is only irritable or present to a significant degree and represent a noticeable change from usual behavior. And we got one, inflated self esteem or grandiosity. Two, decreased need for sleep, e.g., the patient feels rested, uh, well rested only after 3 hours of sleep. Three, the patient is more talkative than usual, or there's pressure to keep on talking. Four, the patient displays flight of ideas or a subjective experience that thoughts are just racing. Five, distractibility. Um, uh, this is where attention is too easily drawn to unimportant or irrelevant or external stimuli or details. Um, Six, there's increase in goal-directed activity, either socially or at work or at school or sexually, or there's psychomotor agitation, which is purposeless, non-goal directed activity. Seven, there's excessive involvement in activities that have a high potential for painful consequences, such as engaging in unrestrained buying sprees, having sexual indiscretions, um, or making foolish business investments. C, the mood disturbance is sufficiently severe to cause marked impairment in social, occupational functioning, or necessitate hospitalization to prevent harm or to self or others, and or there may be psychotic features. So this is a real thing that really separates mania from hypomania. The fact that the impairment is so significant, um, that there's that occupational or social functioning is nil, and generally the person has to be hospitalized or or isolated from their normal environments. Um, D, the episode is not attributable to the physiologic effects of a substance such as a drug of abuse or medication and other treatment or any other medical condition. And in this case here, we note that the patient states he had his last drink or last uh, use of cannabis approximately 30 days before his presentation. So we pretty much know that this his behavior is not the effect of being intoxicated or going through some type of withdrawal. Um, Note that a full manic episode emerges during antidepressant treatment, either with medications or ECT, electroconvulsive therapy, but persists at a fully syndromal level beyond the physiological effects of that treatment is sufficient evidence for a manic episode and bipolar 1 diagnosis. And that means that antidepressants can sometimes push people up into mania, as well as ECT or any other treatment for depression. And if that upswing uh, lasts longer than what should be um, um, generally seen with the use of that medication. Um, so if you start somebody on antidepressant, they get really hyped. And if you stop the medication or you stop the ECT treatment, but that manic episode continues, and this is probably would be in an undiagnosed bipolar person, then that mania is not just attributed to that intervention. It's its own biological, um, you know, pre-programmed condition, and you would consider that episode a true manic uh, event, and then you could go ahead and make the diagnosis, the formal diagnosis of bipolar 1. Okay, does everybody get that?
Yes.
All righty. So let's go on to now discuss. Oh, and one note: um, at least one lifetime manic episode is required for a diagnosis of bipolar 1. So if a person has a full blown episode of mania, you can go ahead and make the diagnosis of bipolar 1 disorder. So now let's talk about hypomanic episode. Um, this is a distinct period of abnormally or persistently elevated, expansive, or irritable mood, and abnormally or persistently increased activity or energy lasting at least 4 consecutive days. and present most of the day, nearly every day. So there's a minor difference between mania. Mania generally has to last a week, a full week, whereas hypomania, you can just have 4 days of it. B, during the period of mood disturbance and increased energy or activity, three or more of the following symptoms, four if the mood is only irritable, have persisted, and they represent a noticeable change from usual behavior and have been present to a significant degree. And I'll go over the different characteristics. One, inflated self esteem or grandiosity. Two, there's a decreased need for sleep. A person feels rested only after 3 hours. Three, they're more talkative than usual, or there's a pressure to keep talking. Four, they have flight of ideas or a subjective experience that their thoughts are racing. Five, they're distractible. Once again, attention is too easily drawn to unimportant details or irrelevant external stimuli. Six, there's an increase in goal directed activity, either socially at work or at school, or sexually, or there's psychomotor agitation. Seven, there's excessive involvement in activities that have a high potential for painful consequences, the unrestrained buying, sexual indiscretions, foolish business investments, etc. Um, C, the episode is associated with an unequivocal change in functioning that is uncharacteristic of the individual when they are not symptomatic. D, the disturbance in mood and change in function are observable by others. E, the episode, this is important, the episode is not severe enough to cause marked impairment in social or occupational functioning or necessitate hospitalization. Um, and if there are psychotic features, the episode is by definition manic. So in hypomania, you don't necessarily get sick enough to where you have to be hospitalized. But if there are features of psychosis, paranoia, delusions, auditory visual hallucinations, then by definition, that gets catapulted into a manic um, level situation. And then at that point, it would be bipolar one. So the difference between bipolar one and bipolar two is mania versus hypomania. And the difference between mania versus hypomania is one, generally, the manic people get hospitalized and they uh, may or may not have psychosis. And the hypomanic people do not get hospitalized and they generally do not become psychotic. In order to be manic, you generally should have the symptoms for at least 7 days. Hypomania, at least 4 days. Everybody get the difference?
Yes.
All righty.
Yes.
All right. So hypomanic episodes are common in bipolar 1, but are not required for the diagnosis of bipolar 1. So people have hypomanic episodes during their bipolar condition. Okay? So let's go ahead and talk about the major depressive episodes that occur during these bipolar situations. All right. Five or more of the following symptoms have been present during the same 2 week period and represent a change from previous function. At least one of the symptoms is either a depressed mood or loss of interest or pleasure. So here, um, the depression should last at least 2 weeks. Um, uh, And note that these symptoms are not clearly attributable to any other medical condition. And I'll go over the different symptoms. Uh, they're depressed most of the day, nearly every day, is indicated by either a subjective report, they feel sad, empty, or hopeless, or observations that are made by others where they appear tearful. And note that in children and adolescents, there can be an irritable mood. Um, and that's generally how depression expresses in kids, more irritability as opposed to true depressive symptoms. Number two, um, there's markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, as indicated by either a subjective account or by observation. Three, there's significant weight loss when not dieting or weight gain, maybe a change of more than 5% of body weight in a month, or a decrease or an increase in appetite nearly every day. And in children, um, just consider a failure to make expected weight gain, as part of their growth. Um, Four, insomnia or hypersomnia nearly every day. So sleeplessness or too much sleep. Uh, Five, psychomotor agitation or retardation nearly every day, generally observable by others, but not merely subjective feelings of restlessness or being slowed down. So they have to be, the agitation or retardation should be noticeable by others, um, and not just self report. Six, there's fatigue or loss of energy nearly every day. Seven, there are feelings of worthlessness or excessive or inappropriate guilt, which may become delusional, psychotic at a level, nearly every day, and not just merely self reproach, self reproach or guilt about just being sick. Um, Eight, there's diminished ability to think or concentrate or indecisiveness nearly every day, either by subjective account or observed by others. And nine, there's recurrent thoughts of death, not just a fear of dying. There may be recurrent suicidal ideation without a specific plan, or there may be suicide attempt or a specific plan for committing suicide. So there's a full range of kind of suicidal thoughts, behaviors, um, that could go on. B, the symptoms cause clinically significant distress or impairment in the social, occupational, or other important areas of functioning. C, the episode is not attributable to the physiological effects of a substance or any other medical condition. So, once again, this guy here, he's out of the window. His last drug use was just about 30 days before admission. Note, in order to constitute a medical depressive, major depressive episode, um, um, the MDEs are common in bipolar 1 disorder, but are not required for the diagnosis of bipolar 1 disorder. So in bipolar 1, you just need to have one manic episode and you get the diagnosis. You don't have to wait for a major depressive episode in order to have bipolar 1. Okay. Um, um, Anybody have any questions so far about major depressive episode as part of bipolar?
Not at this time.
Alrighty, good. Um, so, um, so once again, the criteria in order to have bipolar 1 disorder, the criteria have been met for at least one manic episode, and two, the occurrence of the manic episode and the major depressive episode is not better explained by a schizoaffective disorder, schizophrenia, schizophreniform, delusional disorder, or any other psychotic disorder. So, um, take home point, bipolar 1, you just need to have one manic episode. Um, and and that manic episode should not be attributable to any other um, psychiatric condition or drugs of abuse. Okay. Now, what is the rationale for the diagnosis in this particular case? The patient meets the DSM 5 criteria for bipolar disorder, manic with psychotic features, because there's a distinct period of abnormally elevated mood lasting at least 1 week, and it required his hospitalization. During this period, there was some grandiosity, flight of ideas, pressured speech. Um, he had psychotic features, thinking people could read his mind. The episode was not attributable to a substance or another medical condition. The patient's current presentation, the family history, as well as the Patients report of his cyclical moods over the past few years support the diagnosis of bipolar disorder. Um, Anybody have any questions about the rationale for the
No.
diagnosis? All right. All right. So, what tools or tests should be considered to help identify the correct diagnosis here? Blood alcohol level and urine drug screen to rule out, um, um, a substance causing the problem. If there was evidence of a recent alcohol or cannabis abuse, a diagnosis of substance induced mood or psychotic disorder should have been considered. Okay. All right. Let's move on to the diagnosis of alcohol use disorder, moderate. Um, Diagnostic criteria. All right. This is a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least two of the following um, criteria occurring within a 12-month period. All right. We got 11 of them, and I'll name them one by one. Alcohol is often taken in large amounts or over a longer period than was intended. Two, um, two, there is a persistent desire or unsuccessful efforts to cut down or control alcohol use. Three, a great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. Four, there's a craving or strong desire or urge to continue to use the alcohol. Five, there's recurrent alcohol use resulting in failure to fulfill major role obligations at work, school, or at home. Six, there's continued alcohol use despite despite having persistent or recurrent social or interpersonal problems caused by or exacerbated by the effects of the alcohol. So the person just continues to have social interpersonal problems, but just continues to shrink despite those events. Seven, important social, occupational, or recreational activities are given up or reduced because of the alcohol use. Eight, there's recurrent alcohol use in situations in which it is physically hazardous, such as driving or managing, industrial equipment, etc. Nine, alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the alcohol. 10, tolerance as defined by either of the following. One, there's a need for markedly increased amounts of alcohol to achieve intoxication or the desired effect, or there's a markedly diminished effect with continued use of the same amount of alcohol. So, in order for the person to feel good, they got to use more, or if they use the same amount, they don't get the same feel good um, experience. Withdrawal as manifested, 11 is withdrawal as manifested by either of the following. Um, a characteristic withdrawal syndrome for alcohol um, occurs, and B, alcohol or any closely related substance such as a benzodiazepine has to be taken in order to relieve or avoid withdrawal symptoms. Okay. Does anybody have any questions about the different diagnostic criteria for alcohol use disorder? All right. Then what is the rationale for this diagnosis in this patient? All right. This patient meets the criteria of at least 4 to 5 symptoms of alcohol use disorder, moderate, because he has one, problematic pattern of alcohol use leading to clinically significant impairment, evidenced by consuming larger amounts than was intended. That's his incessant use. Two, um, he continued to use despite having persistent problems caused by caused by the effects of drinking alcohol. 3, he had hazardous use, which is the blackouts. 4, his alcohol use is continued regardless of the knowledge of the physical or psychological problems that could occur. Um, and he describes those sporadic episodes of binge drinking since the age of 17. And I think he said he had been arrested for trespassing and he was intoxicated at the time. So his alcohol puts him in very precarious situations, but he continues to use despite that. Um, let's talk about the. Oh, before I go on, are there any questions about the rationalization of the alcohol use diagnosis in this patient?
No, not at all.
All right, good. What differential diagnosis should be considered? And I mentioned cannabis use disorders. Although the patient reported a history of cannabis use since the age of 17 in a binge type pattern, not enough information is available to identify a problematic pattern of use leading to clinically significant impairment or distress. However, if the patient or his family would provide additional information that would indicate that he does meet the criteria for cannabis, um, however, the patient or his family could provide additional information that would allow us to go ahead and give him the diagnosis of cannabis use disorder. So um, that could be made in the future. Um, so let's go ahead and move on to the formulation of the treatment strategy. So, question is, what treatment would you prescribe, and what is the rationale? All right, I'll tell you what the author says here. They mentioned valproic acid, ER, 1,000 milligrams daily. So that's Depakote ER, extended release, 1,000 milligrams daily. Um, and I guess that's a good dose to start. Normally, I'd start a little lower, but this is a young man, so you can probably take it up to 1,000 at the onset. Um, the first goal of treatment is to control the manic and psychotic symptoms with psychopharmacology because the patient understood that he had bipolar disorder and needed treatment. Options for medication were reviewed with him within the constraints of the hospital formulary, and he was given a choice between lithium and valproic acid as a mood stabilizer, and he chose the valproic acid. Current evidence recommends a combination of lithium or valproic acid with an antipsychotic for severe cases of mania, and particularly the antipsychotic if they got psychotic features. Uh, in this case, risperidone 2 milligrams BID was started for the psychotic symptoms, and he was also given trazodone 100 milligrams at night for his insomnia. So basically, Valproic Depakote ER 1,000 milligrams daily, risperidone 2 milligrams BID for the psychotic features, and trazodone 100 milligrams at night was given for his sleep. Does everybody feel good about that medication regimen or have any questions about it? Would someone do anything differently? All right. Yeah, this is a pretty standard approach. I generally go with the Depakote and add a little Risperidol. I probably wouldn't put anybody on 4 milligrams of Risperidol starting off. I'd probably maybe go 1 or 2. And the Trazodone is a okay. Um, and this is of note: in a person has mania with psychotic features, if you treat the mania, the psychosis will go away. I mean, so you can. It's probably good to add the antipsychotic But if the person had maybe some problems, dystonic problems or or some Parkinsonian features or anything like that, you could just treat the mania and the psychosis should go away. Now, in a case like this, if you did treat the mania and the psychosis didn't go away, you need to consider some additional diagnoses. The primary one would be schizoaffective disorder, because in schizoaffective disorder, people have discrete episodes of a mood problem, either depression or mania, and a separate um, cycle of psychotic um, uh, um, features or a psychotic condition, and they occur during the same illness, but they're two separate sets of events, and that's another way you can distinguish between bipolar disorder with mania with psychotic features, or major depressive disorder with psychotic features, versus schizoaffective disorder. Because if you treat the mania or if you treat the depression, the psychosis should go away in BAD or MDD. If it doesn't go away, then you're dealing with a schizoaffective disorder. Does everybody follow that line of thinking?
Yes.
All right. All right, we'll go on to some diagnostic tests. Laboratory tests to monitor for valproic acid levels. Well, you should get laboratory tests to monitor the valproic acid levels, and LFTs to identify any hepato toxicity or pancreatitis, are set up for that, are essential. So, um, liver function tests should be undertaken. Therapeutic drug levels are for Depakote should be 50 to 100 uh, um, micrograms per cc. Sometimes you can go up to 150. I usually range 50 to 150. Some people need a little more. Initial labs should be include the liver function tests, CBC with differential, and coagulation test. Um, if a patient is female, a pregnancy test is indicated because valproic acid does have the potential uh, for teratogenic side effects. So you have to be very careful with females and make sure that they're not pregnant if you're going to put them on Depakote. Uh, AIMS testing or evaluation for movement disorder should be undertaken. The patient should be evaluated for medication induced movement disorders that may be caused by the risperidone. Neuroleptic induced movement disorders include neuroleptic induced Parkinsonism, acute dystonia, acute akathisia, and tardive dyskinesia. Neuroleptic malignant syndrome is another potential complication with the neuroleptics, and symptoms include muscular rigidity, dystonia, akinesia, mutism, obtundation, and agitation, along with the fever, sweating, and elevated blood pressure and pulse. This is a life threatening disorder and will require ICU treatment. Laboratory findings include elevated white blood counts, elevated CPK, liver function tests, plasma myoglobin, and myoglobinuria. So that's just a take home point. If you're going to put somebody on a neuroleptic, just make sure that you get your AIMS testing and you monitor them for abnormal movements, and always be on the lookout for the most severe of adverse effects with these medications, which is the neuroleptic malignant syndrome, fever, muscle stiffness, confusion. If you get a call from home, somebody's having these events, and it seems more so than just the dystonia, make sure they get to the hospital ASAP. Um, any questions about the diagnostic testing, adverse effects, side effects? All right. Referrals, referral options. They'll be limited obviously by the type of insurance that this patient has, he should be referred to hospital affiliated enhanced outpatient program that would provide him with medication monitoring, cognitive behavioral group therapy, including groups that addresses substance use as well as individual counseling. So partial hospitalization program, IOP, would be good for him, and one that has a SA component. Um, the family should be referred to an intensive family support service in order to help them better understand the patient's illness and the need for treatment. The type of psychotherapy, we discussed that in the referrals. As far as psychoeducation, depression and the Bipolar Support Alliance, DBSA, is a national organization that provides support and education for patients and families affected by bipolar. Um, and local chapters can be accessed at DBS, DBS, dbsalliance.org. Um, as far as psychoeducation about medications, um, the valproates and the risperidone, they can get that information at NAMI.org. Uh, what standard guidelines would you use to treat or assess this patient? The standard guidelines are in the Clinical Management of Bipolar Disorder, a review of evidence based guidelines, and this could be um, downloaded from the ncbi.l. Uh, nlm.nih. So it's nih.gov, probably is the easiest way to get to it, get to this particular guideline. But the American Academy of the American Psychiatric Association should also have um, uh, guidelines for the treatment of bipolar. Um, clinical note: if the patient tolerates a starting dose of valproic acid of 1,000 milligrams daily for at least 3 days, and his blood level is within the lower range of 50 to 100, the dose can be increased to 1,500 milligrams daily. The valproic acid level should be checked after any increases in the medication, and particularly before discharge to make sure it is within a safe range. Additionally, his risperidone dose may need to be adjusted depending on the degree of remission of the psychotic thinking or the development of any side effects. All right. There's also the possibility that the patient may have less binge substance use episodes if his mood is stabilized. However, if his substance use continues to be a comorbidity, it should be addressed concurrently. And at this point, the patient will have a dual diagnosis, a separate bipolar diagnosis as well as um, a consistent alcohol uh, use disorder diagnosis. Um, Sometimes people may use substances to self medicate. And if you treat the primary problem, then the secondary substance use issue may go away, but it may subsist as its own individual diagnosis and requires formal treatment and intervention. Three, among patients taking valproic acid, there is an increased risk in hepatotoxicity in people who have mitochondrial diseases. Uh, these are neurologic diseases such as MELAS or MRF. They're just situations where there's mitochondrial um, aberrations and people may not be able to metabolize um, uh, the valproate molecule uh, as they should, and they may have some abnormal liver responses. So, it's always important to look at those liver functions tests, and if something does go awry, you got to check ammonia levels, etc. All right. Any questions about the case study, um, the history, the examination, diagnosis, treatment? I was going to go over a couple of questions with you. Oh, yeah. Was there a concern, an issue, a comment?
No, Dr. Brown, I don't have any questions.
All right, let me see there. I think there was one. There was a case. All right. I think I got it right here. All right, so let's just do some quick quick Q&A. All right, we got a 16-year-old male presents for evaluation of mood and concentration. The parents first noted a problem with this patient's mood in middle school after a falling out he had with a friend. He became sad and no longer seemed like a happy child. His appetite decreased. He lost weight. He was sleeping too much. His energy was low, and his movement seemed slow. He also lost interest in playing sports, which he really enjoyed prior to the falling out with his friends. He started to keep himself in his room. Parents also found a suicide note, and when questioned about it, the patient denied writing it. It took about 2 to 3 months for this sad mood to resolve. Now, in the past few weeks, the patient's mood has been too elevated. His energy levels are too high. His self esteem is elevated. He has been saying that he's extremely more intelligent than the rest of the kids in his class, and he has been overly flirtatious with the female students. He's been talking a lot and has been researching artificial intelligence lately, and he's been doing this late into the night, and he's been found pacing around the house. He now seems like he's just the life of the party. So here are the multiple choice questions. What is the diagnosis or diagnoses in this patient? We got one, major depressive disorder, two, substance abuse disorder, three, schizophrenia, D, bipolar disorder, or E, none of the above. What do y'all think the diagnosis is?
D.
Yep, it's D, bipolar disorder. The patient has a history of major depressive disorder, but he is currently manic. And because of that manic episode, he meets the criteria for bipolar 1 disorder, currently episode manic. All right. Question two, which of the following psychotherapies is used for this disorder and focuses on keeping routines and and a consistent sleep schedule? We have A, cognitive behavioral therapy, two, dialectical behavioral therapy, C, family focused therapy, D, interpersonal or social rhythm therapy, E, multifamily psycho educational group therapy. Which one do y'all think it is out of those five?
G.
Yep,
Interpersonal rhythm therapy.
yep. The answer is D, interpersonal and social rhythm therapy, which teaches patients the importance of keeping routines and a consistent sleep schedule. Um, when people don't sleep very well, we do become a little hypomanic. So, in someone who does have a bipolar diathesis, uh, not getting enough sleep could push them into mania or hypomania. So, that's very important. Question three: which of the following medications would be the best choice in treatment? We got A, Zoloft or sertraline. We got B, lorazepam. We got C, aripiprazole or Abilify. We got D, venlafaxine. And we got E, risperidone. So out of those five sets of medications, which would be the best for this patient? We got any takers?
Will it be Abilify?
Risperidone.
The
Abilify
answer the
is
answer
D.
is Abilify, which is C, aripiprazole or Abilify. Uh, The risk of weight gain in risperidone is higher than aripiprazole, so aripiprazole is the best choice. All right. Question number 4. Which of the following disorders is most comorbid with the disorder in this case? We got 1, oppositional defiant disorder. We got 2, attention deficit hyperactivity disorder. We got 3, conduct disorder. We got 4, anxiety disorder. So, which disorder is most comorbid with bipolar?
ADHD.
The answer is B, ADHD. Attention deficit hyperactivity disorder is the most comorbid disorder in patients with bipolar. All right. Let me see if I may have a few more questions. Well, I'll tell you what, it's 9:30, and I know you guys got to get to work. Does anybody have any questions at all or comments um, about this case study? There's none. All right.
I have a question, or
All right.
maybe like so we had a patient who was bipolar, but I guess now I'm thinking about it, she was more so manic and then depression. And then so for her, I think we did what mood stabilizer and antidepressant, and then I just realized like here this person wasn't really depressed, they were just more so like mania with psychotic features. So I guess like you for bipolar, is it either you're always doing the mood stabilizer and either you're doing the antidepressant or you're doing the mood stabilizer and you're doing the antipsychotic? Because I just realized she wasn't on antipsychotic, but she didn't have any, you know,
Well, well,
delusions or anything like that.
I mean, well, this guy did have some mood symptoms, but mainly he, the hanger here was the mania. So, in order to have a diagnosis of bipolar affective disorder, and in bipolar 1 you got to have the mania, bipolar 2 you have to have the hypomania, but the treatment is to use the mood stabilizer, and the mood stabilizer by itself should take care of the ups, if that's all the disease consists of, and the ups and downs if they have both. You don't necessarily have to give the person an antidepressant medication if they have bipolar. Now, if they have just major depressive disorder, then using an antidepressant alone works. But in bipolar disorder, all you need to do is add a mood stabilizer. And if they have psychotic features, you could add the antipsychotic time limited. But once again, if you treat the mania or the hypomania, well, like I said, if they're hypomanic with psychosis, then it's officially a manic episode. If you treat the mania with a mood stabilizer, everything should go away. The psychotic problems, the depressive swing downs, and the person can be maintained um, on that mood stabilizer alone. Um, in a psychotic disorder like schizoaffective disorder, you're going to have to use both um, an antipsychotic and maybe a little bit of of an antidepressant, you know. And in major depressive disorder, you just need to use the antidepressant. Does that answer your question? But
Um,
it's oh, go ahead.
Yeah, so I guess like for him, because I guess like the recommendation was what antipsychotic and mood stabilizer. So technically, like if they were having like a lot of delusions, like extreme paranoia, you could add it, and then you could just take away. I guess as they're coming down,
Yeah,
You can
you
take
could
the
take away
psychotic.
yeah, you could take away the antipsychotic. But note now that they have antipsychotics that are both moods that are used primarily as mood stabilizers now. So if you put some
Mhm.
if you didn't want to use if they had
Like
a
a
liver
Abilify.
yeah, if they had a liver problem and you didn't want to use the Depakote or any one of those strict mood stabilizers, or if they had something going on with their kidney and you didn't want to use the lithium, then you could use Abilify or Seroquel, and you would just treat them long term with that. And in that case, you would they would literally be on an antipsychotic, but they're also classified as mood stabilizers, and that could be the monotherapy to manage the bipolar condition. But
Okay, that makes sense.
it sounds like your patient did it sounds like your patient is actually bipolar. Um,
Yeah, but
is
she
it-
had like she had those really lows, so she kind of like waxing away between like the mania and then the depressive episodes. So she didn't really have any of those like psychotic features. So for her,
right.
she was on the mood stabilizer, but then they also added like an antidepressant.
And oh yeah, well, like I said, they just have to be careful because once again, you can still have bipolar with or without the depressive episodes. So
Right.
she would still be bipolar. But if she
Hmm.
had the depression, if they're going to add the antidepressants, they just need to be careful because those antidepressants could fight the mood stabilizer and actually push her up into mania. That's
Okay.
why when someone's bipolar, you just really just want to treat them with a mood stabilizer if you can. Or
Okay.
one of the antipsychotics that works as a mood stabilizer, such as the Seroquel or Abilify. Even risperidol and some of the other ones have gotten mood stabilization indications or bipolar indications. But just be very
Makes
ginger
sense.
with it.
Thank you.
All right. Any other questions? All right. Well, if there aren't any other questions, I'll let everybody uh, get to work seeing patients. Y'all have a good day out there in the clinics, okay?
Thank
Thank
you.
All
you.
right. Thank
Bye
you so
Thank
bye.
you.
much.
Thank you.
All right. Bye bye.
Yeah. Bye.
Bye.